All right. Bismillah, salam, rasulullah. Good evening, everybody. I hope you're having a great time, and hopefully we are coming an end to these webinars and more coming with real seminars. Today we're discussing heart failure, especially heart failure with preserved ejection fraction, a disease that's been emerging day by day, and we're seeing more and more challenges in it, either at the level of the families or the patients, and definitely at the level of how to manage it. In order to understand heart failure with preserved ejection fraction more and more, I'm more than honored to be a moderator for this session. We'll have me as a presenter for the burden of the disease, followed by Dr. Eric McWilliam, and we will hear more about the pathophysiology of HFpEF and related comorbidities. Then Dr. Amar Chaudhary, the principles of cardiovascular assessment in patients with HFpEF, and we'll close with Dr. Mariam Al-Qusseir, patient journey. Without further delay, if you allow me, my dear colleagues and audience, I will start the first presentation. So, heart failure with preserved ejection fraction, or as we call it, HFpEF. Something about the disease burden. At the beginning, we have the global definition of heart failure that was just launched in last November. And we learned from it that they're all the same when it comes to symptoms and signs. So symptoms and signs of heart failure, whether what volume overload as a level of dyspnea, orthopnea, PND, and so on and so on. So we're talking, when we say heart failure, symptoms and signs, we actually cover everything. What about quality of life? Unfortunately, they all have a drop in quality of life. The clinical summary score, the overall summary score, the total symptom score, more or less, they are at the same range, in which they have the drop that really affects people's life, whether they're patients or family. Now we have a higher rate of all-cause readmission observed among patients with HFpEF versus HFrEF. Now HFrEF is an abbreviation, as we all know, for heart failure with reduced ejection fraction. And this comes from the Get With the Guidelines heart failure registry that's being carried for some years by the American Heart Association. And we can see that HFpEF accounts for almost 50% of heart failure hospitalization. And with time, this number really grows because we understand the disease more and more. So 53% of hospitalization are HFrEF versus 47% with HFpEF. So more or less, it's 50%. There is 40% of HFpEF readmission versus 48%. So it is carrying a burden when it comes to hospitalization and the rehospitalization. Now we have in readmissions, we have probably numerically more in cases of heart failure with preserved rather than reduced ejection fraction for 5 years events rate. Continuing with the same registry, we find that 50% of patients with heart failure have preserved ejection fraction. Now, these are with the prevalence are estimated approximately 50%. The proportion of incidence of preserved ejection fraction has increased from 47 to 52. And finally, the characteristics of those patients were older, mainly ladies, in these rather than patients with reduced ejection fraction, as we're going to see in the coming slides. So shifting from that to a cohort study, we find that the same principles, the same findings, very high rate of hospital readmissions. We had this understanding or belief that patients are protected with their ejection fraction. Unfortunately, they're not. So we have the 30 days readmission, 1 year, and 5 years. and we can see that it keeps growing with time. So when all-cause readmissions for heart failure with preserved ejection fraction, we reach up to 84% on a 5 years scale. Again, it has a poorer outcome, definitely with these numbers. So 50% die within 5 years, and this is more or less as in reduced ejection fraction. 3 to 15% hospitalization, more hospitalized in hospital, mortality rate. And then we have 37% that patients will expire following, mortality following hospitalization as a poor outcome indicator. And then we have an average from 10 to 36% of annual mortality, unfortunately. So no more protection for patients with normal ejection fraction if they have the symptoms and the criteria of heart failure diagnosis that includes high BNP. What about the global prevalence? Look at here. If you look at the left, it's more than 50%. So we're looking at preserved, and here is the reduced, and the mid-range is somewhere in the middle. And we can see that different registries has shown more or less 30 to 50% average prevalence of percentage of patients with preserved ejection fraction among the cohort of that registry heart failure. Again, they're more fragile, more elderly, multiple comorbidities, and this has been showed also in multiple studies, as we can come and see it. The prevalence of chronic condition, whether hypertension, hyperlipidemia, ischemic heart disease, and so on, malignancies, strokes, COPD, they're really, really high in such patients, just adding more and more burden on the patients and their family. So in a preliminary summary, we can say that HFpEF now is a dominant in age-related population. In order, more likely ladies, more comorbidities, and the prevalence and incidence of HFpEF are quite relevant to that. So in the ejection fraction, in the era from 2005 going up to 2010, we can see that among the cohort of heart failure, there is an increased proportion of heart failure with preserved ejection fraction, with ejection fraction more than 50%. And definitely these are coming with the newer definitions and newer understanding of the disease and how to pick up those patients, whether in hospital or outside hospital. Hospitalization, as we can see, it's more or less the same. There is no improvement of hospitalization, unfortunately, probably because of the medication or the way we manage. We still really don't understand. Still, reduced ejection fraction carries a higher rate of mortality than preserved ejection fraction, whether these were cardiovascular or all-cause mortality. That when it comes to a pure number of mortality, and it's always correlated with hospitalization as a poor indicator. Now, there is quite an interesting difference in the cause of death. Now, we can see in the reduced ejection fraction, the sudden death is the predominant part, where in the reduced ejection fraction, it's the non-cardiovascular deaths. And just put in mind, these are that comes with more of the comorbidities that are more and more with these patients. Other cardiovascular causes are almost equal in all categories. Now, it does carry a major public problem because there is no improvement in the outcomes. It keeps, dropping as we go all over the years that this disease was observed. When we talk about 5 years mortality, we can see that we almost lose half of our patients. So after diagnosis, yes, the overall mortality, as I mentioned, grows up to 50%, and the specific cause of death now in randomized controlled trial is carried more and more into sudden cardiac death being in the reduced ejection fraction rather than the preserved ejection fraction, in which we have less of sudden cardiac death. So hospitalization is the key factor of the whole dilemma. The rate grows with time. The readmission is quite of a burden, and the major guidelines, the major registries, sorry for the delay, the major registries of such as Get With The Guidelines, Heart Failure, records these and are proven also by other registries. Now, there is an increase, as I mentioned, in the mortality related to hospitalization. And we can see that the heart failure hospitalization, all-cause mortality, cardiovascular death, all become very high if we have a prior hospitalization, compared to almost half if we don't have a prior hospitalization. So as I just mentioned before, hospitalization carries a very strong risk for a prognosis when it comes to mortality. So Saudi Arabia, we have some few studies that I will be short in presenting. So we have I prefer the prevalence of heart failure with preserved ejection fraction in North Africa, Latin America, and the Middle East. And Dr. Wael Hamid was representing the member from the JCC. And it says that what we've mentioned before, it is an older and larger population in ladies, higher hypertension, higher comorbidities, and including obesity and so on. In a study that we've done in the Western region, covering more than 2,000 patients, and earlier, we come to a conclusion that it's more common again among ladies with a higher rate of diastolic dysfunction in echo, and the reduced ejection fraction was more in males with a different phenotype for the cardiac imaging. The Hearts database is the registry that we really count on in Saudi Arabia, conducted by Professor Khalid Habib and many of our colleagues here. And it says that, and it looked at the echocardiographic prevalence, and we can see that it's 26.7%. And we compare it to other registries, we find that we're more or less the same, whether it was Adhere, Optimize, European Society of Cardiology, and so on. So we are more or less on the same prevalence. In another study, heart failure in the Middle East and Arab countries, current and future perspective. Sorry for that. Oh yes, we can see that here is the Gulf area in green, and we can see that more or less the risk factors for ischemic heart disease, dilated cardiomyopathy, hypertension, more or less the same globally. And finally is the clinical characteristics of the heart's chronic in Saudi Arabia, conducted by Dr. Walid Al-Habib and his colleague. And we can see that 50% of the Saudi HFpEF patients have similar comorbidities like COPD, obesity, and so on, hypertension. Internal medicine and general cardiologists, rather than heart failure specialists, are the one conducting the management of such patient. Majority of cardiologists perceiving HFpEF as severe as HFrEF, whereas most of primary consultant physician perceived HFpEF as significantly less severe than HFrEF. Now, the reason for referral are either clinical picture to suspected cardiac cause, referral to cardiology after echocardiogram. And if we look at the burden, we can see that as a continuity, the higher prevalence is associated with substantial morbidity and mortality. And this is what we have in our country. Approximately 50% of patients have HFpEF, but the prevalence is increasing, as we showed in the previous studies. And this study is showing that the Saudi experience is more or less, but when it comes to age, we are 10 years younger than the North America and Europe registries, whether we're talking about HFpEF, preserved or reduced ejection fraction. Unfortunately, this carries more and more misery for our patients. And and my final slide is that preserved ejection fraction, as I mentioned, it was 27%. Sorry for repeating that, but the repeated hospitalization in the Saudi experience was a progressive burden with poor quality of life and a limited survival. And the general population aged more than 60% were identified to have heart failure with preserved ejection fraction. With that, I hope that I give some shade on the Saudi burden and the overall burden of heart failure with preserved ejection fraction, and some touch on our researches that has been in this area. I hope I am sticking to time because my colleagues has requested some extra. Okay. Oh, I exceeded my time. Sorry for that. So may I now ask Dr. Eric to join us, please, and share his slides. Dr. Eric McWilliam is a former chief of cardiology at the Journal of American Heart Association, Johns Hopkins Hospital, and he's a consultant cardiologist, and he will be presenting today the pathophysiology and comorbidities of heart failure with preserved ejection fraction. And Dr. Eric, the screen is yours.
Thank you very much. I presume you can see my screen and hear me okay. Well, it's a great honor to be asked to talk about HFpEF. And I'm going to start off by, again, reiterating what Professor Kamal has mentioned about the typical symptoms of heart failure with breathlessness, ankle swelling, elevated JVP, pulmonary congestion, ascites, and peripheral edema. This is due to reduced cardiac output or elevated intracardiac pressures at rest or during stress. And when I started my career, heart failure, the concept was a hemodynamic one that was due to pump failure, where there was systolic failure of the heart. We had no idea about preserved ejection fraction in those days, and even our understanding of HFrEF was very limited. Now we understand that HFrEF activates a lot of the neurohormonal pathways, particularly the renin-angiotensin system, the sympathetic nervous system, and others. And this causes a lot of remodeling and worsening of LV function. And that knowledge has led to the development of very effective therapies targeting the sympathetic nervous system, the renin-angiotensin system, nephrolysin system, et cetera, And this now has led to an amazing improvement in the life expectancy and also the quality of life of our patients. And by, for example, by very aggressive therapy with a NARNI, beta blocker, MRA, and an SGL2 inhibitor versus an ACE and ARB, that we can get a definite survival benefit. Even at an old age, you can nearly gain another 1.5 years for an 80-year-old by switching to a very aggressive drug regime. And this is one of our patients here who became asymptomatic on guideline-directed medical therapy for HFrEF, and his ejection fraction normalized. So what about heart failure with preserved ejection fraction? When this first came on the scene, we thought this was just due to stiff heart muscle that can't relax normally. Now our understanding is that it's more subtle than that. This is one of our patients who presented with heart failure, and I think everyone will agree the ventricle is contracting very well. However, if we look at more advanced echo techniques, we can see there are signs of systolic dysfunction as evidenced by reduced global longitudinal strain. as well as high filling pressures. This patient had an infiltrative cardiomyopathy. What about heart failure with preserved ejection fraction? We've already heard that this typically involves older patients, particularly females. But if we think about them, they have a huge list of comorbidities. They're obese, they've got systemic hypertension, a large burden of diabetes, particularly here in Saudi Arabia and the Gulf region. Many of them have renal dysfunction, many of them have anemia and iron deficiency. A lot of them have sleep disorders, particularly obstructive sleep apnea. And there's a high burden of chronic obstructive pulmonary disease. And many years ago, or not so many years ago, there used to be a fight between internal medicine and cardiology. Is this heart failure? Is it pulmonary disease? And I think now we've moved on from that, and we realize that these patients have a lot of comorbidities, and yes, they do have heart failure as well. It's important to exclude certain things like pericardial constriction or valve disease or severe coronary disease. Many of these patients have moderate coronary disease, but patients presenting with 3-vessel disease and left main stem disease, those patients obviously require revascularization and shouldn't be considered simply as HFpEF. There are rarer causes such as infiltrative cardiomyopathies, inflammatory cardiomyopathy, genetic cardiomyopathies such as hypertrophic cardiomyopathy, amyloidosis, Fabry's disease, etc. But what's happening in the heart? What's happening in the heart in these patients? In HFpEF patients, we begin to see myocyte hypertrophy, we see systolic and diastolic dysfunction, but even at a cellular level, there are energetic abnormalities, there's interstitial fibrosis and inflammation, there's increased oxidative stress and endothelial dysfunction, and difficulties with the microcirculation. Whereas in HFrEF, the basic mechanism, if you like, is more simple. It really involves myocyte loss or stunning. If you take myocardial infarction as a good example, you lose the myocytes and you replace them by scar tissue. In HFpEF, we get a lot of other changes as well. We get an increase in vascular resistance, increased arterial stiffness, and abnormal ventricular arterial coupling. There's a reduced LV long-axis systolic function, which we've seen with the reduced global longitudinal strain. You get slowed early diastolic relaxation, reduced LV compliance, and increased end diastolic stiffness. But also you can get a reduced LA, left atrial reservoir contractile function, and impaired right ventricular function and chronotrophic incompetence. And remember from your basic physiology, the cardiac output is heart rate times stroke volume. And these patients have a reduced stroke volume. So they're very dependent on heart rate, and HFpEF patients poorly tolerate bradycardia. Typically, they have high LV filling pressures at rest or on exercise and may develop fluid retention or expanded plasma volume. And sometimes in patients where the diagnosis is difficult, you may have to do an exercise test to see if you can unmask the diastolic dysfunction. And I think some of our later speakers may address that. There is this Paulus hypothesis. Paulus and co-workers proposed a novel paradigm in 2013 for the development of HFpEF, where they said there's a lot of comorbidities. Again, obesity, diabetes, chronic kidney disease, hypertension, all these things create a pro-inflammatory milieu that results in systemic inflammation and dysfunction of the endothelium, not just in the heart, but also in the lungs, kidneys, and skeletal muscle. In the heart, there's coronary endothelial inflammation and dysfunction resulting in coronary microvascular dysfunction, and if you like, localized ischemia due to this. There was a very nice lecture given at the American Society of Echo in 2019 by Dr. Shah, who's done an awful lot of work on HFpEF, and he gave a very good lecture. This is one of his slides, and I think this is very helpful for us. The vast majority of our patients have the phenotype, if you like, of HFpEF with all the multiple comorbidities, the obesity, the diabetes, renal failure, et cetera, et cetera, et cetera. On one end of the spectrum, you could have the pure cardiac patients, for example, with hypertrophic cardiomyopathy or amyloidosis. And on the other end of the spectrum, you have the pure renal failure or liver failure patients. But the vast majority of HFpEF patients are in the middle. And these patients do develop cardiac causes of increased LV filling pressures, as well as the non-cardiac causes. And so it's intuitive that we're not going to cure these patients by just treating heart failure. We have to deal with the comorbidities and the other problems associated with that as well. Dr. Shah proposed different phenotypes of HFpEF, and from his work clinically, and also work that he presented at the American Society of Echocardiography. And he described three groups: the BMP deficiency syndrome, where these patients had the least cardiac remodeling and dysfunction and the lowest BMP levels. They had moderately elevated LV filling pressures and LA enlargement. Then you move to the extreme cardiometabolic syndrome. These have the highest prevalence of diabetes. They have more severely impaired myocardial relaxation, higher filling pressures, but still with preserved ejection fraction. And probably the sickest patients are the right ventricular failure, cardioabdominal renal syndrome, HFpEFs, with preserved ejection fraction. They have the most severe cardiac remodeling. If you look at the echo, there's marked right ventricular enlargement. They have the most electrical remodeling with arrhythmias and bundle branch blocks, and they have renal dysfunction, and they get progressive abdominal distension and sepsis, etc. It's interesting in the this is a case from his lecture, a 76-year-old lady with what he called the BMP deficiency syndrome. Look at her BMI, 46 kilograms per meter squared. And this patient presented with overt heart failure, BMP 28. We would all agree that's a normal or low BMP level. But this patient had proven heart failure, did require invasive technique to show that there was uncoupling between discordance between the right ventricular and left ventricular filling. These patients are usually younger than the older patients with HFpEF. They're more obese, they're more prone to fluid accumulation. They can be difficult to diagnose. The arrows at the top of the screen show pericardial fat pad, both on echo and MRI. In the second pheno group, these patients have a high burden of comorbidities. And it's very interesting that the greater the number of comorbidities, the worse the systolic function is, as diagnosed by reduction in longitudinal strain on the left in red, and also diastolic dysfunction. The more comorbidities you have, the worse the diastolic function is, as evidenced by tissue velocity, E prime velocity. Also, these patients have reduced coronary flow reserve as well. And again, this is done by adenosine testing. Finally, the third group was the right ventricular failure cardioabdominal renal syndrome. And these patients are very sick. They have ascites, they've got a lot of peripheral edema, they have chronic splanchnic congestion. And this causes changes in the gut microbiology, a lot of inflammation, a lot of inflammatory response in the body. They develop many infections. They have cachexia and sepsis. And you may recognize these from your clinical practice. They have recurrent admissions with urinary tract infections and pulmonary infections as well. And many times they'll end up on the internal medicine service, but yet have advanced heart failure as well. In our own heart failure clinic in Dhahran, we had 484 patients attending the clinic, and this was the male and female breakdown. And again, we had fairly equal numbers of HFpEF 201 versus HFrEF 213, and 70 patients with mildly reduced ejection fraction. If we look at the HFrEF, as expected, there's a male predominance, but in the HFpEF, there's a female predominance, 124 females versus 77 males in the HFpEF. And again, this goes with the literature as we've seen previously. What about readmissions? Roughly equal numbers of readmissions with HFpEF and mildly reduced ejection fraction, higher number with HFrEF. And if we look at comorbidities, a lot of patients, diabetics, hypertension, coronary disease, atrial fibrillation, obesity, pulmonary hypertension, and obstructive sleep apnea. These are the comorbidities we saw in our patients. So what about HFpEF? I think the way to think about this is that patients have the milieu, they have the obesity, the sedentary lifestyle, poor level of fitness, the aging, they've got obesity and metabolic stress. They end up with vascular and ventricular stiffening, hypertensive remodeling of the heart, and a global loss of not only cardiac, but also vascular and peripheral reserve. And they end up then finally with the syndrome of HFpEF. So it's intuitive to think that perhaps many of these patients there could be a preventative aspect here if we prevent obesity, if we properly control hypertension, if we control diabetes, if we can manage all these comorbidities and encourage people to a healthier lifestyle, managing weight and regular exercise, there would be a lower burden of HFpEF. We can't, unfortunately, prevent aging. This is a typical patient, one of our patients, 84-year-old male, multiple admissions with heart failure, but also multiple admissions with chest and urine infections, diabetic, atrial fibrillation, old stroke, dementia, previous pacemaker or heart block. He had a remote history of sarcoid disease, but actually no evidence of cardiac sarcoid involvement. These were his BNP levels. You could see at times the decompensation became very elevated, over 1,000. But look at his LV systolic function, very well preserved LV systolic function. Global longitudinal strain reduced to minus 10.5%, big atria, his ejection fraction by 3D, 63%, but pulmonary hypertension, a restrictive pattern of LV filling, high filling pressures as measured by E over E prime velocity, dilated left atrium, and requiring high doses of diuretics to keep him out of failure, frequent admissions. So probably this patient is more towards the cardio-abdominal type of the spectrum, with frequent admissions with sepsis as well. There's another patient, 67-year-old female, again, BMI of 37 kg per meter squared, previous breast cancer and irradiation, mild to moderate coronary disease, atrial fibrillation. And this lady, again, you can see she's obese, she's presenting with heart failure, with pleural effusions, but her BNP levels are relatively low. So she's tending more towards the BNP deficiency type. But look at her ejection fraction. Again, normal ejection fraction, left atrial enlargement, a grade 2 diastolic dysfunction, high filling pressures as evidenced by a tissue Doppler, some mitral regurgitation. But look at her echo here. Again, we see on the parasternal axis here, we can see pericardial fat pad. And this is a common finding here from subcostal view, a lot of fatty infiltration in the liver. These patients have generalized metabolic stress throughout the body. And her global longitudinal strain slightly reduced to minus 15.1%, but ejection fraction well preserved, but yet presenting with recurrent heart failure. And finally, an 82-year-old man presented in February this year with edema and shortness of breath. You can see he's in some pulmonary congestion. He has quite marked hypertrophy, a lot of LVH, but his ECG showed low voltage. He's got a big LV mass, 245 grams. And you can see his preserved ejection fraction, maybe slightly reduced ejection fraction, but this patient had restrictive filling, very high filling pressures. And this is probably the key here. He's got what we call the cherry on top. This is a patient who has preserved apical function with this pattern of global longitudinal stress that's very suggestive of cardiac amyloid. And sure enough, his cardiac bone scintigraphy scan was positive for ATTR amyloidosis, and he had no evidence of light chain disease. So this patient had ATTR amyloidosis, and it's important to pick these up because there's now specific therapy for these rare conditions. So in conclusion, we've gone from just thinking about HFpEF as a stiff heart that just can't relax normally to, in most patients, where we have multiple comorbidities that have to be managed with our colleagues in internal medicine. We have to treat sepsis. We have to manage obstructive sleep apnea. We have to manage renal failure. We have to manage diabetes. but we have to manage the cardiac causes as well. And hopefully in the future, we'll have a clearer understanding where some of our HFpEF patients will be divided into different categories, and there'll be specific therapies or specific regimes that will help us understand these patients. So thank you very much.
Thank you very much, Dr. Eric, for sharing this these details about heart failure. Actually, I learned a lot. May I ask Dr. Amar Chaudhry, my dear friend, to start uploading his file. So our next speaker for today is Dr. Amar Chaudhry. Dr. Amar is one of the pioneer consultants in heart failure in Saudi Arabia. He's a consultant cardiologist, advanced heart failure, and echocardiographer in King Faisal Specialist Hospital and Research Center in Jeddah. Today's Dr. Amar will discuss the principle of cardiovascular assessment in patients with heart failure with preserved ejection fraction. Dr. Amar, the screen is yours.
Thank you very much, Dr. Kamal, and I would like to, thank the audience for joining us this evening, and also would like to thank the sponsor for organizing this session on a very, very important topic. This is really challenging for not only cardiologists, but anyone who's at the front line of the HFpEF epidemic. Now, diagnosing HFpEF has gained a new level of importance in light of clinical trials that for the first time have shown that we have therapies that can reduce hard clinical endpoints, either definitively or potentially. And so it's more important now, more important than ever before, to identify the likely responders to these treatments, and also to recognize that there are patients that may not respond to therapies. So it's important to avoid using them in people that will not respond and will be exposed to the potential side effects of these medications. So to illustrate some of the finer points in this discussion, I will share with you a case that I think most of you can relate to, because we've all encountered someone like this in our practices. So this is a 65-year-old woman who's been evaluated for dyspnea with ordinary activity for 1 year. She has diabetes. Her BMI is 31. But her physical examination is completely normal. Her NT-proBNP is completely normal. And her echocardiogram report says that it is also normal. So there's a wide differential diagnosis for her dyspnea on exertion, but one of those possibilities is HFpEF. And the question is, can these features exclude the diagnosis of HFpEF reliably? So what we're going to do is that we're going to address the individual elements in this case as we go along, and we'll come back to it towards the end of this discussion. So anyone who talks about the diagnosis of HFpEF mentions how difficult and challenging it is to diagnose, and this may seem like an overused term, but not only it is true, understanding why that's the case is important because it helps us understand the evolution of our approach to diagnosis of HFpEF. And the first issue that comes up is the issue of ejection fraction. EF is normal in HFpEF, and despite the limitation of this metric, when you have the constellation of signs and symptoms of heart failure and the ejection fraction is reduced, the diagnostic certainty is higher that those features are related to the reduced ejection fraction. But when the ejection fraction is normal, it is more difficult to ascribe those features to the syndrome of heart failure. And that's the exact reason why HFpEF as an entity was not recognized until relatively recently. And experts continued to debate its very existence for a very long time. That's no longer the case, of course. Then there's the issue of what is considered a normal ejection fraction, because if you look at the practice guidelines, an EF of more than or equal to 50% is considered normal. But the American Society of Echo guidelines will tell you that a normal EF is more than or equal to 52% in men and more than or equal to 54% in women. And when you factor in the variability in EF reporting, the fact that reduced EF is defined as less than 40%, you can understand why clinical trials of HFpEF have pretty much defied these guideline recommendations. This debate has also been reignited or fueled, if you will, by the demonstration that there is potentially an interaction between the effectiveness of new therapies along the continuum of ejection fraction. And perhaps they're effective all the way to an EF of 60%. And then afterwards, the effectiveness starts to attenuate. And we see that signal not only with sacubitril/valsartan, but potentially with empagliflozin, and also in post hoc analyses with candesartan and spironolactone. So this is something that casts a doubt over the clinical value of the 50% cutoff, and that's something that future research and guidelines will have to address. But until that happens, practice guidelines consider EF of more than or equal to 50% as the cutoff, with all the caveats that we mentioned. What about the clinical utility of clinical assessment, which is considered the bedrock of clinical medicine? Well, we have findings that are supportive of heart failure, be it by history or examination, but the sensitivity of these findings is generally poor. And that's usually the case because many patients present with heart failure in the earlier stages, so they don't have overt signs and symptoms of heart failure. But with respect to specificities, they tend to be higher in general. But in the case of HFpEF, even the specificities can be low. And that's because, as Dr. McWilliams nicely mentioned, HFpEF is a syndrome of comorbidities. And these comorbid conditions mimic heart failure. They essentially masquerade as heart failure and produce features that are almost identical sometimes to heart failure. So that creates another limitation as far as clinical assessment is concerned. Now, we look at clinical trials for HFpEF. Historically, they have relied on two criteria. One is an ejection fraction criterion, and the other is the clinical diagnosis of heart failure. And not only these trials were negative, the event rates of patients enrolled in these trials were lower than expected for HFpEF from community-based studies. And that's partly because many patients without heart failure ended up enrolled in these trials. So when investigators set out to look at the role of spironolactone in HFpEF in the TOPCAT trial, they were very mindful of this. And TOPCAT was the first trial to include NT-proBNP as an optional inclusion criterion. And the potential effect of having this as an inclusion criterion was immediately apparent. Now, we know that the results were different according to the regions where patients were enrolled. And that's largely thought to be because those enrolled in the Americas, the vast majority were enrolled on the basis of high NP levels. So their event rates were typical for heart failure, and spironolactone seemed to benefit them, whereas those enrolled in Russia and Georgia probably did not have heart failure because they were enrolled largely on the basis of clinical evaluation. So this was the trial that cemented the role of natriuretic peptides in the diagnosis of HFpEF, both on a clinical level, practice guideline level, and future clinical trials, above and beyond the ejection fraction and clinical assessment. However, natriuretic peptides also come with their own shortcomings. So remember that patients with HFpEF have a normal left ventricle in terms of size, and LVH is common, and both of these factors counteract wall stress, which is the key determinant of natriuretic peptides. So on average, natriuretic peptide levels in HFpEF patients tend to be lower than the HFrEF counterparts. And then there are other factors, clinical factors that affect the level of natriuretic peptides, including obesity, the cardiometabolic syndrome, aging, and so on and so forth. So even the guideline endorsed cutoff of 125 in one important study missed the diagnosis of invasively proven HFpEF in about 20% of patients. So that means that there are limitations for each of these individual parameters. Yes, you will have the patient that comes to the ER, like the one showed by Dr. McWilliams, with overt heart failure, congestion, where the diagnosis is very straightforward. But there will be patients where the diagnosis will be difficult despite having these individual parameters. And that raises a question of whether or not we have a diagnostic gold standard for HFpEF? And to answer that, we go back to the original definition of heart failure as conceived by Professor Braunwald. So heart failure is defined as the inability of the heart to meet the demands of the peripheral organs, or the ability to do so at the expense of elevated filling pressures. So in other words, the failing heart will maintain normal perfusion when the filling pressures are high. So even though this definition is lacking on the specifics, it is nevertheless a conceptually sound definition. And subsequently, experts have expanded on this foundational definition. In the European guidelines, for example, heart failure is defined as having symptoms and potentially signs, which is an acknowledgement that signs could be absent in the early stages of heart failure. You also need to demonstrate structural abnormalities that fit the phenotype of heart failure, which in the case of HFpEF is typically left atrial enlargement with or without left ventricular hypertrophy. And there should be the demonstration of a functional abnormality, which in the vast majority of patients is elevation in filling pressures at rest or during exercise. And that's another important statement, because if the abnormalities are only present during exercise, the testing for filling pressures is performed at rest, the diagnosis of heart failure could be missed. Now, when you apply these principles to the subgroup of patients with HFpEF, we can understand how the guidelines reach these criteria for defining HFpEF. So you need to have clinical features. There's an ejection fraction cutoff. There is an NT-proBNP cutoff. There's a need to demonstrate at least left atrial enlargement, LVH, or diastolic dysfunction. Now, diastolic dysfunction is typically assessed non-invasively with echocardiography. You can make an assessment of whether relaxation is impaired or not, and you can make an assumption of filling pressures using echocardiography. However, it is presented as an optional criterion for diagnosing HFpEF, even though there was a time when HFpEF was known as diastolic heart failure. Now, the switch in terminology from that to HFpEF is for a couple of reasons. It's basically to de-emphasize the role of diastolic dysfunction. Not that it is not present, it is ubiquitous, but it is not the only factor that contributes to the syndrome of heart failure. There are non-cardiac contributors, like the ones mentioned by our colleagues, including frailty, aging, COPD, anemia, what have you. There are also cardiac factors other than diastolic dysfunction that contribute to heart failure, such as atrial dysfunction and chronotropic incompetence and subtle degrees of systolic dysfunction in the left ventricular RV. Then there's the issue of the fact that filling pressures can essentially be normal at rest, and most of this testing is performed at rest. And there's also the major issue, related to the diagnostic accuracy of the parameters that we have for diastolic dysfunction, because unlike systolic dysfunction, that can be relatively easily diagnosed with a single metric, which is ejection fraction, the diagnosis of diastolic dysfunction requires multiple parameters. And the reason for that is because on an individual level, each of these parameters has poor diagnostic accuracy to differentiate between health and disease. So you can have a parameter that is completely normal in someone with clear-cut heart failure, and you can also have a parameter that is abnormal in someone who is completely otherwise healthy. So to expand on this, what we are looking at on a routine basis when assessing diastology is looking at the pattern of diastology. And the E wave here represents the passive flow of blood from the left atrium to the left ventricle, which is along a pressure gradient between the left atrium and the LV. And the higher the pressure gradient, the higher the velocities of the red cells. So we look at that. And we also look at myocardial relaxation velocities using tissue Doppler imaging at the basal septum and the basolateral segments of the left ventricle. And this is the term used for that is E prime. And typically, the basal septal E prime is more than 7 or 8. The lateral E prime is more than 10. However, if you look at normal individuals above the age of 60, about half of these people will have a septal E prime and a lateral E prime less than 8 and less than 10 respectively. So this parameter by itself is not going to be helpful unless it is severely reduced. Another parameter that goes along with chronic elevation in LA pressure is enlargement of the left atrium. So an LA volume index of more than 29 was considered previously abnormal, but to increase the specificity, this was revised to more than 34, and still 6% of healthy individuals above the age of 60 will have an LA volume index above 34. With respect to the ratio between the E velocity to E prime, if you use a cutoff of greater than 14, it is very rare to have that in healthy individuals. So this is very helpful if it is present. It's highly specific, but there will be people who will have an elevation in LA pressures at a lower E over E prime. So if you're using the cutoff of 14, the specificity is high, but the sensitivity is relatively low. And if you're using a cutoff of 9, you enhance the sensitivity at the expense of specificity. And the same applies to TR velocity cutoffs, which are also difficult to acquire because a lot of times you have an inadequate TR signal. So in 2016, the American Society of Echo convened a committee to revise the guidelines to simplify the approach to diastolic assessment and filling pressure assessment as well. And this committee recommended not one, not two, but 3 out of 4 criteria to be met in order to diagnose diastolic dysfunction, which is a pretty high bar to meet. So they made the diagnostic criteria quite specific at the expense of sensitivity. And these were consensus-driven, recommendations that needed external validation. So the same group of investigators prospectively looked at a number of patients with invasively proven elevation in filling pressures, and they looked at the diagnostic accuracy of clinical assessment and echo. And in the subgroup of patients with ejection fraction of more than 50%, the accuracy of clinical examination was quite poor, which is not surprising, but echocardiography using these criteria improved the diagnostic yield and accuracy to around 84%, which is excellent, but it is not 100%. And remember, this is, as part of a study done in expert centers. And therefore, it's not surprising that other investigators were not able to exactly replicate these high numbers. And the agreement between the diagnostic accuracy of echo with invasive assessment was only around 75%. So why is that? That's partly because of the multiple parameters that are required, and partly because most of this testing is performed at rest. So how to overcome this issue? One solution is to perform diastolic stress testing. So you can consider that in someone who has a high clinical suspicion of HFpEF with grade 1 diastolic dysfunction or borderline numbers in general. Like in this example, you have a patient with a lateral E prime that is less than 10, an E over E prime that's less than 14, and TR velocities that are not quite 2.8. And when they exercise, their values become clearly abnormal with high E to E prime and a high TR velocity. Now, some of these can be physiologic. So that's why the specificity of diastolic stress testing with echo is not the greatest. The diagnostic gold standard, however, is right heart catheterization. And the cutoffs that are recommended by the Mayo Clinic are wedge pressure of more than or equal to 15 millimeter mercury at rest, or more than or equal to 25 millimeter mercury with exercise. And this is, difficult to perform. The exercise is done using supine bike, and this is the type of equipment that is not readily available. So what is the value of doing diastolic stress testing above and beyond routine assessment for HFpEF? Now, we have some data from the Mayo Clinic on this because they have a specialized dyspnea clinic. And what they looked at is patients with invasively proven HFpEF and patients with undifferentiated dyspnea. And in this important paper, there were a couple of remarkable findings. One of them was that NT-proBNP was less than the guideline recommended cutoff of 125 in about 18% of patients with invasively proven HFpEF. And that highlights the limitation of NT-proBNP as a single criterion. They also showed that right heart catheterization at rest was highly specific, but not very sensitive. Exercise right heart catheterization was able to reclassify 44% of patients with non-cardiac dyspnea as having HFpEF, and that's why it's considered the diagnostic gold standard. With respect to resting echo, it performed extremely poorly in this particular cohort with poor sensitivity. Exercise echo improved the diagnostic yield at the expense of specificity. So in other words, if you'd perform diastolic stress testing with echo and it is normal, that has a high negative predictive value. If it is positive, it can be a false positive, and the gold standard remains right heart catheterization. When is this performed? It's performed at tertiary, quaternary centers, where there are specialized dyspnea clinics or as part of research. These are a couple of examples of studies with intra-atrial shunts and agents that modulate the nitric oxide cyclic GMP pathway where this has been used, but it's not widely available. So this is where clinical scores have been advocated as a gatekeeper assessment tool, that if you have someone with equivocal findings, you may apply a clinical risk score like the CHAS score, for example, to estimate their probability of HFpEF, and based on that, you can decide whether they need additional testing. So there are two scores, one from the United States and the other is from Europe. The US score has the advantage of being more validated. So this was derived from a population of invasively proven HFpEF, and they used regression, logistic regression, to come up with factors that were more predictive of HFpEF. And then they validated this model. And what they came up with is a couple of risk factors, and they assigned weightage to each of these risk factors. So if you end up with a score of 6 and above, the probability of HFpEF is very high. And if you have a low score, you don't need additional testing because HFpEF is excluded. But if you have a value between 2 and 5, you can consider these patients for additional testing, such as diastolic stress testing with echo plus or minus invasive testing. The European score performs somewhat similarly, the idea behind it, but this was consensus-based. So what they did was to assign a score of 2 to findings that are highly suggestive of HFpEF, such as LA volume index of more than 34. But if you have an LA volume index of more than 29, then you give a score of 1. And similarly, if the total score is more than or equal to 5, HFpEF probability is very high. But if the score is 2 to 4, you can consider additional testing. The problem with these scoring schemes is that they lack external validation. The US score has been looked at retrospectively, applying it to the TopCat population. It performed reasonably well, but in a Canadian study, it was as good as a flip of a coin. The criticism of that study is that these patients were not diagnosed with HFpEF using the diagnostic gold standard of invasive testing, whereas the European score has not been validated. With respect to comparing these two scores, it seems that they perform reasonably well in identifying high-risk population, but each of these scores is missing the high-risk population that is identified by the other score. So there is a degree of disconcordance of around 28%, which tells you that the scores have some inherent flaws. So how do we put this all together? If you have a suspicion of HFpEF, my approach is that you start with that clinical suspicion, you order echo and NT-proBNP, and part of the reason you do that is not only to assess diastology, but also because you want to exclude alternative causes, non-cardiac causes like pulmonary causes, renal causes, et cetera, and also the cardiac causes that mimic garden variety HFpEF, like coronary disease, low flow, low gradient, severe aortic stenosis, hypertrophic cardiomyopathy, amyloid, constrictive pericarditis. If you exclude these probabilities, then your diagnosis is still equivocal, you may consider applying the scoring schemes. And if the result of the scoring scheme is still equivocal, you may consider diastolic stress testing or invasive assessment. The role of clinical phenotyping, as it was mentioned by Dr. McWilliams, is still a concept that has not been validated yet, but this is something that is going to come in future once we have treatments that are tailored according to the specific phenotype. One question that people would always ask is, we don't have diastolic stress testing routinely. We don't have access to that. What I would like to remind you is that the clinical trials that have looked at the effectiveness of therapies in HFpEF their inclusion criteria largely mirrored the criteria mentioned in the guidelines, namely clinical assessment, ejection fraction, NT-proBNP, and evidence of LA enlargement. They were not based on comprehensive diastolic assessment. They did not do diastolic stress testing or invasive hemodynamic assessment. So, what that means is that the findings of these trials are, even if they're positive, we don't know if they're generalizable to patients that are diagnosed with HFpEF on the basis of diastolic stress testing or invasive hemodynamic assessment. So let's go back to our case. Remember, this is a 65-year-old woman who has dyspnea on ordinary activity, diabetes, BMI of 31, but otherwise everything is normal. So what you want to do is you want to rule out non-cardiac contributors to her dyspnea. You want to rule out other cardiac explanations like coronary disease, like aortic stenosis, et cetera, et cetera. So if those are ruled out, you want to look at the individual numbers. The NT-proBNP being normal is not enough. You want to look at the NT-proBNP value. In this case, it was 80. You want to look at the echo report in more detail. So these are the numbers here. And if you apply the American Society of Echo criteria, she has only one criterion, which is lateral E prime that is less than 10. So this would be considered normal. But again, look at the LA volume index is 32. It's not quite 34, but it is above 29. So in this ambiguous case, because the clinical suspicion is there, you may consider applying both of the risk scores. And when you apply them, the US score gives you a score of 4. The European score is also in the intermediate range. So what you need to do ideally is to perform exercise stress testing or invasive hemodynamic assessment. From a pragmatic standpoint, however, if you don't have access to these tests, look at the patient's profile. The fact that she's diabetic alone may qualify her anyway for treatment with an SGLT2 inhibitor. All right, so I'm going to conclude here. This is going to be my sort of final comment, that the diagnosis of HFpEF is, not always straightforward, but the fact that we have clinical trials that are positive, look at the inclusion criteria of these clinical trials. They're relatively simple. And from a treatment standpoint, I think it's relatively easy to decide who would be a candidate for therapy and who would not be a candidate for treatment. Thank you very much.
Thank you, Dr. Amar. As usual, a stunning presentation. And we're a bit delayed, so we will shift immediately to Dr. Mariam Al-Qusseir. Dr. Mariam, can you please unmute your mic? Thank you. And Dr. Mariam will be presenting the patient journey. Dr. Mariam is a very well-known heart failure cardiologist in the Western Province and the Kingdom. She's actually a consultant cardiologist at King Fahd Hospital. And she has quite a big interest in heart failure, and in oncology cardiology. So let's hear today from Dr. Mariam about preserved ejection fraction and patient journey. Dr. Mariam, the screen is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, dear chairpersons, dear speakers, dear colleagues. Thank you so much for attending this session, and thank you very much for the organizing committee to arrange this webinar series, which is very much needed. I know we're short of time, so I'm going to try to be as quick as possible. I've been tasked to give a talk on patient journey. And initially, it was a bit, confusing for me, and I wasn't too sure how to start off with that. But I'm just going to walk you through my thinking, and I hope that helps to try to maybe illustrate how difficult it is for patients with preserved ejection fraction to navigate the system today and to get the right treatment, and what are the key challenges with regards to that. So these are some of my disclosures, just as a quick outline. So I'm going to try to make it quite brief. I'm going to describe a quick case scenario. I think we're all trying to kind of put it in the clinical context that, again, demonstrates what a typical heart failure preserved ejection fraction patient looks like. And then just very quickly, and I know this has been tapped on by Dr. Kamal, in terms of the burden of disease in Saudi Arabia and what is really of concern for us today, and looking at, really their outcomes and their quality of life scores in comparison to other forms of heart failure like HFrEF, and then hopefully try to finalize by saying what are the real issues and dilemmas when it comes out to patient journey in this specific cohort of patients in Saudi Arabia. So this is one of my, more challenging, let's say, HFpEF patients, but she is a 64-year-old lady with a background history of long-standing type 2 diabetes mellitus, hypertension. She's on the heavier side with a BMI of 29, and she has CKD stage 3B. She's a dependent within the hospital. She was referred to me for evaluation of shortness of breath from her internist. When I spoke to her, she's been struggling with the symptoms of shortness of breath on exertion for many years. She's severely deconditioned, very quality of life. She's moved her bedroom from the top floor to the ground floor. She's unable to leave the house. She's unable to go out without any assistance. She has a lot of symptoms, according to her daughter, that are suggestive of sleep apnea. She has hypersomnolence. She has abnormal breathing, snoring. Her BP is not very well controlled. Her A1C is quite elevated at 9. And in the clinical sort of setting and examination, she was hypertensive. Heart rate was 90. She'd reduced air entry bilaterally. She's short neck. JVP was very difficult to assess in the office setting. She definitely has bilateral lower limb edema, pitting edema going up to the knees. She was maintained on a number of, like usually as of these patients, they're on a sort of a polypharmacy sort of medications. She's been on amlodipine 5 milligrams, valsartan 80, hydrochlorothiazide 25 milligrams. She was on a small dose of a diuretic, a statin, aspirin, metformin, gliclazide. Her creatinine was elevated at 125. And her BNP, again, we don't have NT-proBNP in our hospital. Her BNP is not super high, but it is definitely elevated for 2 reasons. First of all, she in an ambulatory setting, your cutoff of BNP is much lower than that. So that is relatively elevated. That's one. But the second component is that, she's relatively obese. And so usually these patients have a relatively lower BNP. So this was definitely a red flag in her case. Her echocardiography showed mild left ventricular hypertrophy, moderate left atrial dilatation. I apologize about the spelling mistake, with elevated volume index. And she had a borderline LV systolic function with an ejection fraction of 50%. PAP was about 35. She had some diastolic dysfunction and elevated filling pressures. So what we did for her is, really, got everybody to come along the journey for the patient. So I spoke to the pulmonologist, put her through for a sleep study, changed her medications to sacubitril valsartan in light of the recent studies, and then added empagliflozin, which I wasn't too sure why it was not on. Monitored her renal function very closely in light of these 2 additions and her CKD. And I spoke to her diabetologist in terms of, making sure that we have a more aggressive and optimal glycemic control. We did have a cardiac rehab function in the hospital, but unfortunately recently the person who was leading it had left. So I put her through for an exercise program with physical therapy and nutrition referral. So this brings me just very quickly to, these are Saudi data. It's in the time of COVID, in the era of COVID, we need to kind of compare it to COVID. It is a growing pandemic, unfortunately. We have huge numbers of patients that are diagnosed day after day with heart failure. And unfortunately, there's about a 10% mortality per year. Half of these patients die within 5 years, which is again comparable to lung cancer and quite bad cancers in the world. And about 50% of the patients that come in through the emergency room, even if they're coming in for other symptoms, primary symptoms, not heart failure, do have some symptoms attributed to heart failure. So they come in with shortness of breath and fatigue or leg swelling. So if we just look at, our own hearts registry, which Prof. Kamal has mentioned, what was interesting was that the average age of the patients that were diagnosed, and these are in tertiary centers, were quite young, and 70% of these were hypertensives, and about half or more than half of these patients were diabetic. And that these findings were almost exact with the Gulf Care registry, because you may argue that these are the type of patients that arrive to the tertiary hospitals in an urbanized region. But with the Gulf Care, they had multiple hospitals throughout the Middle East with different sort of, secondary care hospitals, remote and urban areas, but they still had the same demographic population. Now, if we compare it to something like the ADHERE registry from the US, the median age over there of diagnosis is 75 years of age, and no more than 40% of these patients are diabetic. And this is similar across other non-Middle Eastern registries. So we know that our patients, first of all, present younger. They have many more comorbidities. They're more diabetic. They're more hypertensive than our Western counterparts. And what was interesting in the hearts registry, and this was highlighted by Prof. Kamal, was that actually, normally, we usually sort of a ballpark figure is that half of the patients have HFrEF and the other half have not HFrEF. So they would be anywhere between HFmREF and HFpEF. But historically, when these registries were done, HFmREF was non-existent in terms of taxonomy. So what was interesting is that in the hearts and the Gulf Care registries, only a quarter of the patients had preserved ejection fraction, which is an ejection fraction of about 40%, above 40%. And that the reason why this is a bit concerning is for two reasons. The first one is, are we really underdiagnosing these patients? And you can see that anecdotally from our practices, just like what Dr. Eric has showcased, the number is definitely bigger than that. And we see more of these patients, but maybe we're not putting them in the registry because they're not coming to the cardiac services. They're going to internists, they're going to diabetologists, they're going to other physicians, and they may not be labeled as HFpEF patients. Is the question that we're just not diagnosing them, or is there a genuine major discrepancy between the two? And I anecdotally, again, I think the answer is probably the former as opposed to the latter. And what worries me again with these patients and looking at their journey is that, they unfortunately don't get that diagnosis that the HFrEF patients get, if you know what I mean. So they do not get, they don't understand what's happening to them, yet they still have a very poor and morbid outcome. So their outcomes are comparable to patients with reduced ejection fraction, no difference. And in fact, this is a quality of life sort of assessment. The ones in yellow are the ones with the patients with HFrEF, and the HFpEF patients are the ones in gray. And the limitations in terms of doing basic activities of daily living is much more prominent in patients with heart failure with preserved ejection fraction. So not only do they, die as early as the ones with HFrEF, but they also have a very poor quality of life because there's not much that we're offering them, or we're not diagnosing them early enough, and we're not very aggressive about managing their comorbidities. And we know the guidelines are very clearly stating that, we need to do more for these patients. We need to treat their hypertension, identify it early, put them on SGLT2 if they are at risk of developing heart failure for diabetic patients, and making sure that, yes, we do not have class 1A indication for patients with, the mildly reduced ejection fraction. So the ones that are sort of in the MREF category, we know that these patients still, there aren't any major, breaking clinical trials that have shown major benefits, but the same medications that we give the HFrEF patients can work in these patients' populations. So we should give them the benefit of the doubt, and we should start them on things like, an MRA based on the TopCat, sacubitril/valsartan based on the Paragon trial, and obviously SGLT2s based on the Emperor Preserves, for instance. But more importantly, these patients, more than anything else, need a true heart team intervention. So they need not only a heart team, actually a multidisciplinary heart failure team. They need to have, people around the table, internists, physical therapists, nutritionists, diabetologists, a heart failure doctor and nurse around the table, to really a clinical pharmacist, to try to improve their care and try to get the patient as well to be fully activated and be involved in their care, because they are the ones that are, they deal with polypharmacy, they deal with comorbidities, and it's very, very important to try to tailor the care around being patient-centric and being multidisciplinary and holistic in your approach. So this is my last slide, I promise you. I'm sorry, I'm trying to whiz through the slides because of the time. But today, really, the dilemmas with heart failure patients with preserved ejection fraction are the following. They're really lost in the system. Unfortunately, their first stop usually is in the emergency room with breathlessness. And the referrer from that point onwards is anyone's guess. They may go to a primary care physician, they may go to a cardiologist, they may go to a diabetologist, they may not be referred elsewhere. And so continuity of care is lost. It's imperative that we start really identifying these patients early and being very proactive of screening for heart failure in patients with comorbidities, and having a holistic and multidisciplinary approach, being very aggressive in terms of initiation of therapies for diabetes, for hypertension, and so on and so forth. Use biomarkers, use echo to try to guide you in the diagnosis. In the case where the biomarkers, and the echo are not there, but you have a clinical suspicion, usually, as exactly as Amar mentioned, most of the time these patients are diabetic, they're hypertensive, so you are going to start them on these medications anyways. You don't need to do any fancy, refer them to any fancy stress testing if it's not available. But you need to think of it, or else you won't diagnose it. And today you won't diagnose it. And we have guidelines that can support the management. So we need to make the best out of that. I apologize for going very fast through this, but Kamal was going to have my head if I didn't. So there you go. Thank you very much.
Thank you very much, Dr. Mariam. Can I just go straight to some of our questions? We have a question for each speaker, if you don't mind, because of the time again. So I may start with Dr. Eric. How often do you see hepatomegaly in heart failure with preserved ejection fraction?
Well, we can see it, particularly in the group where they have predominant right heart failure. That third group that I mentioned, we can see liver congestion, patients with tricuspid regurgitation, with pulmonary hypertension. Some of our patients definitely will have liver congestion. And again, a lot of these patients are very obese, and they can sequester a huge amount of fluid in their abdomen and liver. And it's amazing sometimes when you get these patients in and diurese them, just how much weight they lose. So again, I think Mariam was saying it's very hard to sometimes see the JVP in our patients. And I'm always surprised by sometimes we bring them in and give them a furosemide challenge, just how much fluid they lose. Yes, we do see it.
Thank you. Dr. Amar, we'll go for the first question. So can the diagnosis of heart failure with preserved ejection fraction includes stiff left atrial syndrome.
I think what the person who asked the question is referring to this condition of atrial myopathy, which is associated with pulmonary hypertension and large V waves in the absence of mitral disease. Yes, I mean, this would be in the spectrum of HFpEF. This is a loose term. HFpEF is a loose term because it has so many phenotypes. So this could be considered as an additional phenotype. But because it's rare, it's not recognized as a separate entity. But atrial myopathy, as part of the diastolic dysfunction that affects the left ventricle is extremely common.
I have a question for Dr. Mariam. So we have a full clinic just trying to serve the reduced ejection fraction patients. So where do you think an optimum setting of care for multiple comorbidities, including heart failure with preserved ejection fraction? Do you feel it needs to be set at the family physician setting, at the general internist, a separate identity? What do you think?
Yeah, I think this is sort of a hot potato. So it's a question that everybody keeps on asking, because we shy away from getting these kinds of patients because we feel like we can do more for the HFrEF patients, and these patients are, they come with a bag of comorbidities that somebody else needs to look after. Ideally, in an ideal setting, now today in Saudi Arabia we're working on this, but ideally this needs to sit initially, first and foremost, with a family physician who is able to manage this, but will have access to other subspecialties like allied health, like the cardiologist, and so on and so forth. So you need access to, for instance, imaging. You need access to biomarkers. You need access to a nutritionist, but really it needs to be sitting with a family physician. Today, the family physicians are not all either equipped with the resources, or maybe don't have the right amount of training or background to manage these. So currently, ideally, we say they sit with internists and we help them with that. It's very difficult, obviously, as you said, to try to manage them as cardiologists, and we probably will do very poorly. And that's why when the patient was referred to me, I kind of called the diabetologist back and I said, I will need your help to manage their diabetes. I can't do that. I can tell you start an SGLT2, which you should have, but beyond that, I can't do much for an A1C of 9. Do you know what I mean? So it needs to be a combined approach. We're very good at treating cancers, right? We have tumor board meetings all the time. And I wonder whether we just need to make sure that we emphasize, multidisciplinary heart failure meetings for these patients and attend them. It wouldn't take much time. But the primary point of contact should be either family medicine or internal medicine.
Let me share with you my experience, my limited experience. Once we look at patients with a lot of comorbidities, obesity, diabetes, and so on, and they're all in the vicious circle. But once HFpEF is introduced as a sort of shortness of breath, then things start to collapse. They cannot perform any sort of exercise, which they did not perform before because of shortness of breath. Very limited offering, except from the continuity of telling them, please lose weight, please lose weight, please lose weight, and move and move and move. If they would have moved, they would have moved 15 years ago, not now. And now they have an alibi, which is they're true. They can't move because of the shortage of breath. The only thing, just like Eric said, is that they get to have a sort of hope with some IV furosemide and losing a lot of weight and get this sense of breathing again. Maybe this pushed them, but the biggest challenge is that till now we don't have basically much to offer them except lifestyle, which is the most difficult thing in medicine. So without further, we've been far enough with this presentation. It's almost 10 o'clock. First of all, I would like to thank really the attendees for bearing with us this 1.5 hour. I mean, the presentation was brilliant. The topic is really needed, and it's a big challenge for the families and patients. I would like to thank Dr. Eric, Dr. Mariam, and Dr. Amar for their wonderful presentation today. Definitely Kunuz Vitaj from Saudi Heart Association, and Novartis for their scientific support, material support. And we will keep wishing for and hoping and praying that science will bring us more help to those patients, whether in terms of easing their burden, understanding them, diagnosing them, or even making their journey better. Thank you very much. Have a great night, everybody, and we'll keep seeing you in this scientific event. Thank you. Assalamu alaikum.